Okay, so we are live now. Hello, my name is Chris Schroeder, and I am the current editor of the ASRA News. Tonight, we were fortunate enough to be joined by the authors of the recent ASRA News article entitled "Nerve Stimulator in Regional Anesthesia, Is It Out of Vogue?" Sorry, just added somebody here. This article was recently published in the November special edition of the ASRA News that accompanied our fall annual meeting. This edition of the ASRA News is full of how I do it styled articles, and I would encourage you to make some time to either read these articles or listen to the podcast as they're ultimately released. Before we get to our discussion, I would like to mention a couple of opportunities that are upcoming or currently available through ASRA. Number one, registration for the 19th annual pain medicine meeting is still open until December 15th, which will get you access to all the content material and 46 CME credits. I can certainly personally attest to the quality of the lectures and really how well the meeting platform functions. So I think it's certainly something worth checking out. And then there is going to be a free webinar on neuromodulation that will be held in partnership with the Association of Pain Program Directors. This will be January 12th at 7 p.m. Eastern Time. So the format for our discussion here tonight is going to be somewhat lightly structured. I have prepared some questions. But if anyone out there has anything that they would like to be addressed, I would love to hear from you, and then I can pass those comments or questions along to the authors, and we can try to make sure that we get to those questions that you have. So now I would like to be quiet for a while. I'd like to ask our authors to please introduce themselves and then discuss why they felt compelled to write this article and how they currently use nerve stimulation in their clinical practice.
Okay. Hello, everyone. My name is Jasmeet Khurana. I'm one of the junior residents at the University of Alberta in Edmonton, Alberta, Canada. So I've had the privilege of working with my co-authors for many years now. And I really wanted to try and understand the theoretical aspects in terms of using electrical nerve stimulation and some of the alternatives that we have, such as ultrasound, which oftentimes is the go-to whenever peripheral nerve blocks are performed. But my main objective when writing this article was to get a lot of the theoretical information and background around it. I haven't had a lot of clinical and practical experiences with utilizing peripheral nerve blocks and administering them just yet, but just to get more background and learn from my fellow colleagues as well.
Hi, my name is Vivian Ip. I am a clinical associate professor at the University of Alberta Hospital, and I will be working with Jasmeet in his next regional block. I feel that nerve stimulator is underused since the introduction of ultrasound, and I just felt it's very important to get the message out there that nerve stimulation is still very much alive, and that I use that for all my nerve blocks, I have to say, but in a different way, which we'll go into later. So I do not use that for nerve localization anymore, since we have the ultrasound to help us, but there are certainly there is certainly its place in clinical practice when doing nerve block to kind of enhance safety.
Go ahead, Rakesh.
Hi, my name is Rakesh. I'm a clinical associate professor in University of Iowa in Iowa City, and I work closely with both Dr. Sui, Vivian, and also with Jasmeet. And I think it was a very timely article because most often when we practice regional anesthesia, one of the core skills is the residents or our fellows need to know how to use a nerve stimulator, and most often they don't. They don't even know the physics behind it or the safe way to use nerve stimulator combined with ultrasound guided regional anesthesia. So we thought we'll reappraise the whole science behind it, and also safe way to use it, and also highlight the caveats of using a nerve stimulator guidance. So to sum it up.
Okay, thanks. My name is Ben. I'm a professor at the Stanford University. Actually, I have privilege to work with my colleague here. Actually, one is my former medical student, fellow, and colleague. So we've been working each other for a long time. So it's timely in a way that the nerve stimulation has to be already in our regional for a long time. And just now, most people just more using ultrasound, but the background is there, but actually the functioning is different in a way that you have to understand more the physics, and one is more imaging technique with ultrasound. So I think there's no reason why we cannot using both. It's not mutually exclusive. When the ultrasound, I still remember when we bring ultrasound in the main regional field, a lot of people think that, oh, we don't need nerve stimulation. But I think it's overlooked simple thing, because like almost like anatomy versus physiology, doesn't matter that I would say like nerve stimulation is almost like look at the physiological response. Ultrasound is almost like looking at the anatomy, like the spread and things. So we all know go through medical school, anatomy and physiology go hand in hand. So how you learn it is different things. Okay, I think that will set the platform. Chris, any general question for us, or we can entertain?
Yeah. No, that's outstanding. I kind of agree with you that I think that there are two broad reasons why, the use of nerve stimulation is important. One, and kind of the first one here, maybe we could leap into, is teaching. So, you go through this, you can talk with the residents about anatomy, about innervation, and it's really a good time to sort of review those components of their training that sometimes we get lost a little bit when we just focus on ultrasound imaging and just putting a needle towards a target. Do you guys have, certain circumstances where in the course of training residents, you're more or less likely to use nerve stimulation, i.e., are you more likely to use it early on, because you're maybe less likely to know exactly where your needle tip is? Or are you more likely to maybe incorporate it a little bit later in their training so that you can focus more on another endpoint, not divert their attention away from that, one thing that they're trying to focus on as they're learning?
Yeah.
Go ahead.
Okay, I'll go. So for me, I think teaching the residents, first of all, the principle of how to actually do a nerve block safely using multimodal monitoring, as described in the article. I think the one situation where I can kind of combine the use of ultrasound as well as nerve stimulation is an auxiliary block. I think is nicely demonstrated. Yeah, it's a really nice block for the resident to do. It's superficial. They can actually see the needle, and very satisfying for them. And then it demonstrates all the motor response, and then they can just use the ultrasound skills as well, just trace the nerve back and forth. I think that, in that situation, I think that's a very nice block for the residents who first start to learn about or just appreciate how to use nerve stimulation in different ways, I find.
I also tend to teach our residents at the earliest possible instance, because they not only need to know the basics of using a nerve stimulator, but also, like Vivian pointed out, they need to know what motor responses result in with the respective nerves and what to watch out for, and also know the safe practice, what is dangerous. Like we pointed out in the article, nerve stimulator guidance has high sensitivity, but very high specificity, but low sensitivity. And there is a nice article by, who's this, Vasilov, back in 2012 in ACT Anesthesia, Scandinavia. This is a study performed on pigs where they showed that nerve stimulator combined with ultrasound is much safer than ultrasound or nerve stimulator alone in terms of needle nerve contact or intraneural injections. And I come across my colleagues who always say that, oh, it doesn't improve the efficacy of your nerve block, combining a nerve stimulator to it. I always ask them the question, is it harmful to combine nerve stimulator to an ultrasound guidance? If it is not riskier than what your actually ultrasound is offering, multimodality is probably for the best. And that's how we incorporate that school of thought into our residents and fellows.
Yeah, and also the one thing is that interesting thinking is people think that one will be always beneficial. That's why the whole concept about the multimodal, like in terms of analgesia, but also for localizing the target. For example, one thing we should understand that ultrasound have its limit. Its limit is when the tissue plane get deeper, you may not able to see that well. But in terms of nerve stimulation, doesn't matter how deep, how superficial, the response is more or less the same, so it can compensate each other. I think, like for example, always that we always do for lumbar practice a bit deeper block, you may not able to see the entire needle completely. You're not sure it's the tip or the shaft, so we always turn on both. And everyone to find that if you're using both, you're more reassurance where you're injecting. And on the other hand, also, like for example, one of my main interests is also epidural stimulation. Ultrasound cannot penetrate bone, and now the nerve stimulation can do that for you. So, but at the same time, this not mean that you cannot use an ultrasound. You can ultrasound, find the bony landmark, get the needle close enough, and then you can using stimulation to confirm your location. But I would say, like in the old day, we don't have ultrasound, primarily using the nerve stimulation for location seeking. But of course, now we can see. Of course, we can get to the target quicker with ultrasound in majority superficial target. But also, sometimes when you have some doubt, nerve stimulation can tell you what you're touching. It is a nerve or tendon more specifically. I think one of the primary problems when most people look after, they hang up with the 0.5 milliampere. That's a whole article talking about in a way that because we're looking at physiological response with nerve stimulation, there's no reason why 0.5 is the magic number. This is depend on each patient, what injectly you inject into it. It's almost like say, okay, potassium levels 6 are going to get arrhythmia. It's not going to happen. Maybe when it's potassium becomes 7, 9, you have more chances you get arrhythmia. Same thing when you have 0.2, you get stimulation likelihood in the intraneuron. It doesn't mean that when you don't see it, it doesn't happen. So it just gives you a more probability that what you're touching and where's the location and further on. So it's a physiological response. So everyone is different. Like classically, you can think of simple thing. You give muscle relaxant into it. Doesn't matter you cut the nerve, you still cannot stimulate. So it's all respond to it. Then you can imagine how much muscle relaxant, how much anesthetic on board, like the gas, or it do affect the response to the nerve stimulation. So you have to know it. But if you're using conjunction with ultrasound to confirm your target, then it's totally different things to safeguard where you are versus that how close you are versus that you try to avoid the dangerous area.
Yeah. So we have a great question here from somebody who's watching right now. It says, and this is kind of more of a clinical question, but how do you deal then with a discrepancy between nerve stimulator information and ultrasound imaging information? Which one do you trust if they're not consistent? I mean, I think I see this, kind of commonly in our practice when we try to incorporate both ultrasound guidance with nerve stimulation. If you have somebody with, significant and profound diabetes, you may know that you're putting that needle right adjacent to the nerve, but getting no motor response. So how do you make those two things jive?
That's a very great question. I'll try to answer as much as possible, and I think Dr. Sui and Vivian can chime in too. This is commonly happening not just in neuropathic patients, but even in otherwise healthy patients. And when we trap, like for example, subgluteal sciatic nerve block, you think that's the nerve between quadratus femoris and gluteus maximus, and you try to touch it and there's no tibial twitch or even common peroneal twitch. And should we try to seek a twitch or should we just inject there in the subgluteal fascia itself? We are commonly debating that. Sometimes you think that's the nerve, it may not be. So it's always the discrepancy. So I think ultrasound what has made practice easier is like it is given an objective visual perception of the nerve. We can more rely on the ultrasound anatomy, but the nerve stimulator usage comes into play when you don't have a good sonographic anatomy, and we want to reconfirm it. And that's the question which is rightly pointed out. When you don't have a good ultrasound and you don't get a twitch, what will you going to do? Which one are you going to rely? I would say that ultrasound, as pointed out in that article, has lots of caveats. A single nerve can have minimum stimulating currents varying along the course of the nerve, proximal versus distal. If soft tissue intervening between the nerve and the needle tip can have a different impedance, so that can result in loss of stimulus to lack of stimulation. Again, nerve stimulator performances vary, so there is a lot of different factors which come into play when you are using nerve stimulator. But the basic take-home message is, if you are getting a stimulation at very low currents, at 0.2 milliamps with a pulse duration of 0.1 millisecond, that is either needle nerve contact or intraneural location, and both are kind of bad, because it's been shown that even needle nerve contact can result in inflammatory reaction in animal models. So I think when there is a discrepancy between nerve stimulator and the ultrasound imaging, it depends on what the discrepancy is. If you are getting low current stimulation, you have to trust the nerve stimulator. But if you don't get a stimulation at 0.5 milliamps or 0.2 milliamps even, you may be intraneural, but you would rather rely on the ultrasound image in the lack of a motor response. But in the presence of a motor response, I think you have to trust, depending on the stimulating current you're set in, you have to trust more of the nerve stimulator. I would like to hear what Vivian and Dr. Surya has to say.
Yes, I agree with you, Rakesh. If you do get stimulation at, say, even 0.2 milliamps, then you may be intravesicular. We don't even know. So I would withdraw and then trust the ultrasound image to spread first, and also the injection pressure, the opening injection pressure is also very important. That's why we also incorporate that in our everyday practice by using the compressed air injection technique, which was described in our newsletter as well. And that the injection pressure, basically, if you compress the air by 50% or less, then your injection pressure is less than 15 psi or 760 millimeters mercury, which means that you're less likely to be intravesicular. In fact, there was actually a new article from Catheters in Anesthesia and Analgesia, just kind of hot off the press, and they use a combined injection pressure monitoring and minimal nerve stimulation current, and they find that the combination of that actually presents less chance of being intraneural or doing an intraneural injection. So yeah, Ben, anything else to add? Because that's your method, really, the Kate technique.
Yeah, actually, I totally agree with both of you. But basically, I just want to highlight the point is the whole point we're talking about is nerve stimulation is physiological response. When you see a positive response, the information is extremely useful. But when you don't have a response, can be many things. Can be your electrode is not connect properly. Maybe you inject too much saline. Maybe some dilutional thing. So in other words, when you don't see anything, doesn't mean that it can preclude anything. But when you see positive test, then you can see what's the current. And that is more useful when you have positive test than negative. Like for example, in my practice, very seldom that you think you're a nerve, that one's a nerve, and you point 0.5 no stimulation. Turn it up to 1, 2, 3, you're going to see something. And then when you see something, you pull back a little bit and suddenly disappear. Then you know what you're negotiating, that target is actually a nerve. But just with this nerve is somehow maybe fibrosis, maybe diabetes, they don't respond. Or potentially maybe the patient actually have some muscular medical problem. or maybe they still have some muscle relaxation on board. So when you see, there's a simple take-home message that's saying that when you see positive response, careful look at the number, and then it can help you a lot. I also about the pressure gauge measurement is important, because most of the time it looked like that actually the needle trauma into the nerve probably doesn't cause too much of nerve damage. The reason why I say that is we see a lot of cardiac, plastic surgeon, they repair the nerve by putting a needle through. It's the high pressure we inject into the nerve, get hydrodissection and get inflammatory response that causing damage. In other words, the high pressure we want to avoid is try to not hydrodissect the nerve. We just want to hydrodissect the surrounding area. So I think they seem similar, like the nerve stimulation and the pressure measurement. If you look at from a physical point of view, engineering point of view, that one is mechanical, one is electrical. You can combine the electrical, mechanical indication plus your ultrasound imaging. So none of those is mutually exclusive. So you actually can using all, and none of those are practically not causing anything. Like I know that some company make those pressure gauge. You can use that, or using a simple air thing. Nerve stimulation by tradition, we always have it. Particularly when we have a deep sided block like subgluteal, it's really helpful to touching it to see what you're dealing with. Is it true? Or lumbar plexus, when you have a poor visualization that you want to fine tune what you want to make sure what. It almost like what I find is the ultrasound look good, you get positive response, that block almost work in lumbar plexus and the deep sciatic. But if a good spread, but you don't get the nerve stimulation, sometimes it works, sometimes it doesn't work. So you can imagine that when, in other words, when you see positive, you're more certain than without.
Another thing I'd like to add is for the nerve, you can always trace back and forth, and that gives you a better indication that, the structure that you're looking at is likely a neurostructure too.
All right. So just, I think kind of maybe the final piece about teaching here is that I think in a number of institutions, nerve stimulation is not being taught anymore. And so if you were somebody kind of new to practice, or you're someone who maybe graduated in the last 5 to 10 years where there was just a tremendous amount of enthusiasm from ultrasound guidance, and they hadn't really learned about that nerve stimulator, where do you think people could go to kind of pick up on, some of the intricacies of how to use the device and become facile with it?
So I would say that like what we in medical training, you have to like how intubation, you don't want to start intubation with difficult airway. You want to have a controlled environment. So in other words, sometimes what I teach is commonly, let's say if you have supraclavicular block, you're missing the ulnar sparing, you can do a forearm rescue. Those are nice that you turn on the nerve stimulation. You can see a nerve, you touching the ulnar nerve, and then you can see the pinky moving. So this is really intuitive. And also sometimes it can actually help you a lot in terms of understanding. Nerve stimulation actually, that you stimulate, you can see what move, and actually you can based on that to learn the block. Let's say the patient can move the arm this way or this way, what nerve you're missing. How to demonstrate that you can do the stimulation to illustrate that is controlled by a nerve rather than just a textbook looking at the screen. I think I saw some question on the screen before. One of the common thing is, it's true, sometimes when you inject something, you have blood coming, hematoma or something. The one common problem that people say, oh, that damn nerve stimulator doesn't work. A lot of time because you inject a lot of saline. So basically, we all know that in old school talking, that why we're using insulated needle, because you want to focus the electrical field on the tip so that you can tell what the tip looking at. But if you inject a lot of saline, you basically diverse all the current away from it. So that's why you don't get stimulation. It's nothing wrong with the physiology, but it's just because you change the environment. Now, simple example, people will be understand. That's why in urology, when they do the turb or something, they try to burn something in the bladder because it's full of it. They don't use saline, they're using glycine water because they know that if using saline, they cannot burn anything because current just cannot focus on the tip. So same thing, a lot of people, they start injecting saline because it's the most easier to get on, and they try to stimulate. Of course, you don't see the stimulation. That's why first thing they have to know is they have to understand why the stimulation. That's why we're talking about the dextro 5%. Dextro 5%, particularly for answer that question, when you hematoma, when you have some blood around, inject some D5, it actually will seal the area again. It will regain the stimulation.
Also, I want to add that using dextrose as an initial injectate is also important if you are either intraneural, because you don't want to inject a neurotoxic local anesthetic, so you can safely rule that out along when you're combining that with Kate, especially.
No, absolutely. I think I really like D5W. In fact, without your experiment on the D5W and concentrating that current at the tip of the needle, nerve stimulation will just die, basically, I think. But also, I find D5W as an injectate first before you go onto your local is when you're actually using D5, you know whether the spread is a good spread or whether you do not see any spread at all, which means that you may either you haven't lined up your needle or you are intravascular. So I always use D5W, which enables me to do my nerve stimulation and also to prevent intravascular injection and to for hydrodissection and yeah.
Also, I have to point out that about a hematoma, you can always use impedance measurement if it's available on your nerve stimulator, because if you are into a blood vessel or something with very low resistance, your impedance monitoring should show intravascular needle placement as well. So you can troubleshoot in a variety of ways.
Now, from our listeners, we have a couple really clinical focus questions here. So one is, do you still use stimulating catheters when using when they're placed with ultrasound guidance? Will you still use a stimulating catheter?
Maybe I can tell you clinically, we're always using stimulation catheter for lumbar punctures, always, because without it, what we find if you're just using ultrasound, the catheters, because it's a compound block, but we want to get our catheter or the needle close to the plexus coming out. So we in this situation we always using stimulation catheter for lumbar plexus.
Our institutional practice, we only have stimulating catheters in our supply, so we have had extensive stimulating catheter experience. Even for home regional, we tend to inject all the local anesthetic through the nerve block catheter after eliciting, say, for an interscalene block, after putting the interscalene catheter and eliciting a shoulder twitch, and then injecting after using ultrasound guidance, seeing the local anesthetic injected. I don't know. It depends on practitioner to practitioner, but I think it gives me a little bit more confidence that this block will definitely work when all the local anesthetic goes through the catheter and you get a stimulation through the catheter before that.
It depends on the context, as Rakesh and Ben says. I normally don't use the stimulating catheters, although I have used them in situations where, like special occasions, for example, you do an ESP block and then use the stimulation catheter to actually feed the catheter up to essentially do an scaling kind of procedure. So I've done that for sure. And yeah, some occasional special occasions I do use stimulation catheters. Otherwise, I would use the normal catheter.
Now, do you guys have a troubleshooting algorithm for, what do you do when you get a great twitch or a great motor response from the needle, but anytime you thread the catheter just smidgen beyond the catheter or the needle tip, that twitch disappears? How do you approach that?
I have to say, Chris, I use the catheter over needle device, which is really handy. It looks like an IV, and what I do is I just get my target, use as with my nerve stim. And then once I got my target, you take the needle out, and the needle, the length and the diameter is exactly the same as the inner catheter. So then I feed that inner catheter in, knowing that the tip of that catheter is exactly where the tip of my needle is. And then I just tape it in place, and it works great. So rather than overfeeding, for the traditional catheter, the Saudinger technique, you always have to overfeed the catheter, before you take the tuning needle out, and then you have no idea where the tip of the catheter is. And I find that it's kind of more troublesome, because then sometimes I see the tip of the catheter, but most of the time I don't see the tip of the catheter, and I have no idea whether the tip is actually where I wanted it to be. Yeah.
For this, a lot of time what I find is why the stimulation catheter doesn't work is a lot of time people open up the space using saline or local anesthetic. So once you do that, of course, you already abort the physiology from it, so it won't happen. So if you want to do it, I will using D5. My experience is that usually when you still inject D5, open up a little bit, when you thread the catheter, you still can get the stimulation at the beginning. Of course, when you thread further away, then you may lose it. But then you at least know the catheter is still within that space. But common mistake when I see is people using saline or give the first dose of local and then thread the catheter. Of course, they won't get the stimulation. But now, one thing you can understand that if you still want to confirm it, you turn up your current. If the current still 1 or 2 still gets stimulation, likelihood is still in the ballpark area, haven't dislodged anywhere. Okay.
All right, you guys have been great. I don't want to keep you here all night, so I have one last clinical question for you. And this is, will electrical impedance replace all these monitors for safe performance of regional anesthesia?
I think Dr. Su is the best one to answer, because he has studied electrical impedance for regional anesthesia. He should take it.
Okay. Now, if you look at it, actually, I report that about 10 years ago. At that time, we have energy. I think that will take the answer for us, and then we can safely doing it. But the problem is an interaction between the patient and our needle. Basically, have an interface. That interface we cannot change. Example, like people say, if you have hematoma, you will change the response to it. Actually, if you look at a small paper that published in a small journal, they do changing different frequency, look at the impedance, but the problem is the minute you inject anything, it destroys the physiological response. That's why most in nerve stimulation, neither you have to using strictly D5 or you have a dry needle. Otherwise, none of those impedance matter. And also the impedance, just like you measure person height or weight, it doesn't mean anything. It's the trend of changes. So in other words, that's why I haven't published more on the electrical impedance, because I try hard. I do a lot of animal study because it's unstable environment. That's why my focus on that is I focus more on ultrasound, because ultrasound is anatomy based that slightly better in a way that in terms of they're less affected by the small changes. And that's same thing in ultrasound do have a problem too. If you inject a lot of air, it can destroy it too. But by and large, if you inject a lot of slight amount of fluid, you still the structure intact. But the physiological response by nerve stimulation is really sensitive to your environment changes. So, but as a monitoring device, it's good, particularly when you at the beginning when you want to inject something, you don't want to find out later on, right? So that's why nerve stimulation still have a role, because prevent you to start doing any injection. Like for example, even you using the pressure gauge or something, you still inject something. But nerve stimulation, you can get some information without inject anything. Now, even ultrasound, you have to inject something to see the spread. So basically, nerve stimulation can have a one step ahead before you inject anything to decide that you can tell you where is the tip of the needle, rather than even ultrasound or the pressure gauge. you usually will be much helpful. You need to inject something.
And you have to answer the question that combining all these modalities, multimodal monitoring, is not actually putting any patient to undue risk. It's actually either helping you or probably of no use. Are you still doing ultrasound guided blocks? What these additional data will tell you is, are we safely performing this? Should we withdraw our needle if we are getting low current stimulation? And can we avoid intraneural injection by compressed air injection technique and a vascular marker probably in the injected, these kind of things. And
Yes.
I just have to point out that there is a Swiss national survey of anesthesiologists in last year, published last year, which said that the most popular method of performing regional blocks was combined ultrasound and nerve stimulation technique. So it's not completely out of vogue. There are a lot of physicians who still vouch for combined technique.
I think for me, I definitely use my ultrasound to find the structure, and then I have my nerve stim dialed down to 0.2 milliamps, and then I perform the block. And if I see a muscle twitch there, then I pull back, I withdraw the needle, and my patient will be lightly sedated, so he or she can give me feedback too. And then I use the compressed air injection techniques just to make sure that my opening injection pressure is not too high. And I feel that the D5W, as an initial injectate will help. Firstly, you're not injecting low neurotoxic solution in the nerve, say if you're intraneural, before you even see the spread. So that's how I usually do my nerve blocks.
Yeah, I think to sum it up, we usually keep it at 0.2 unless it's like multi-stimulation axillary brachial plexus block, where we want to elicit the specific twitches and then decrease the current to lose the twitch at low currents and then inject it. But otherwise, for a standard procedure for a femoral nerve block, say, we keep it at 0.2 milliamps and withdraw the needle only when you see the stimulation. That's probably a safer way to do it.
All right. Well, this has been absolutely outstanding. Thank you guys so much. Dr. Sui, Dr. Ip, Dr. Khurana, Dr. Sodakapam, and behind the scenes, Dr. Gupta. I mean, this greatly exceeded my wildest dreams as far as how well this was going to go. To everyone who's listening, thank you very much for joining us. And I look forward to meeting with all of you again in the future as we discuss some of our other ASRA news articles.
Thank you, Chris.
Thank you. Thank you.
Thank you.
All right.
Pleasure.
Right.